Good evening, everyone, and welcome back to the Lipid panel. My name is Dr. Guy Mintz, and I'm the co-chair of programming for the Lipid panel, working alongside my co-chair, Dr. Merle Meyerson. The Lipid panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after a busy clinic, to discuss diagnostic approaches, interpret clinical findings, and generate therapeutic strategies. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you are not alone. If you have any cases or topics that you would like to be presented or be part of our presentations, please email Sarah Hill at shill@lipid.org. In this series, we review common presentations of rare diseases, atypical presentations of common conditions, sometimes even common presentations of common conditions, and we'll try to cover as many important clinical topics that every lipid specialist needs to know. The series is meant to be a monthly coming together, always the last Tuesday of the month, of rising stars and existing stars coming together, including our lipid scholars and our senior mentors and specialists, looking to put together a discussion on various topics through case presentation. So tonight, we're very honored to have with us a super panel, and I like to say the lipid panel is going international this evening. We have Dr. Raul Santos, who's one of our esteemed colleagues from Brazil. He's a preventive cardiologist and lipidologist at the Hospital Israelita Albert Einstein, University of São Paulo, Brazil. He's past president of the International Atherosclerosis Society and a longtime friend of the FNLA, and looking forward to hearing from Raul this evening. As our moderator, we have Dr. Alan Brown, who is an interventional cardiologist and preventive cardiologist. He's currently a clinical professor of medicine at the Rosalind Franklin School of Medicine and Science in Chicago, Illinois. Dr. Brown has served as governor and president of the Illinois chapter of the American College of Cardiology, and subsequently was elected chairman of the Board of Governors for the American College of Cardiology in 2004. He's a fellow of the American Heart Association, the American Society of Preventive Cardiology, and the American College of Cardiology. He is a master of the National Lipid Association, and he's former president of the National Lipid Association. He's written numerous articles and chapters in the area of lipid management and prevention. He is also the host of Lipid Insights and Heart Matters. We're also joined by Dr. Nidhi Patel, who's a third-year internal medicine resident and incoming cardiology fellow at Emory University. She is a current lipid scholar and working toward her goal of becoming a preventive cardiologist. So I'm honored to have everyone joining us this evening, and without further ado, I will let Dr. Patel present this evening's case. Thank you for joining us.
Thank you so much, Dr. Mintz, and thank you everyone for joining today. I'm so excited to present a case to you all and get started on this topic. These are Dr. Santos' disclosures. So this is a case of a 63-year-old female. She has a history of diabetes, hypertension, CKD, stage 3A, hypercholesterolemia. She had an NSTEMI in 2023 and had a PCI to her LAD, and she comes to your clinic to establish care after a local hospital shut down. She was diagnosed with diabetes about 10 years ago. It was previously uncontrolled with an A1C of 10.6, but she's been working towards better control of her diabetes, and her last A1C was 8. She has a past medical history of hypertension. Like we mentioned, she does keep a log at home, measures her blood pressure, and usually it's in between 130 to 140 millimeters of mercury systolic. For her diabetes, it's been complicated by retinopathy and neuropathy. She's had no hospitalizations related to her diabetes in the past. For her medications, she takes amlodipine 5 milligrams, losartan 25 milligrams, metformin 1,000 milligrams twice a day, an SGLT2 inhibitor 10 milligrams, aspirin 81 milligrams, rosuvastatin 40 milligrams, and gabapentin 300 milligrams nightly. She has no significant surgical history. She does have a history of diabetes in her family. Her mother had diabetes, and her mother passed at age 70 from a heart attack. And both her sister and her brother have been diagnosed with diabetes, and both of them were diagnosed in their 50s. There's no other history of cardiac events or stroke in her family. She works in Atlanta, Georgia at a Church's Chicken, and she enjoys painting. She used to smoke five to six cigarettes daily for the past 10 years, but she quit 2 years ago. But unfortunately, she switched to vaping. She drinks two 12-ounce beers every other day, but in the past, she used to drink 3 to 4 12-ounce beers 4 days a week, so she's trying to cut down. She has no history of illicit drug use. We took a 24-hour diet recall to understand her eating habits a little bit better. And for breakfast, she tells you that she has 2 sausage patties and some scrambled eggs with white bread, and she usually slathers on some butter. For lunch and dinner, she has soup, which she tells you is made of beef bone broth, corn, string beans, carrots, and potatoes. She does use olive oil to cook her meals, and she usually uses an air fryer to cook instead of frying her food. For snacks, she loves Lay's potato chips, and she has these usually every day with her lunch. And she eats out about 6 times a month. The last time that she ate out was about a week ago. She is trying to exercise more. She walks about 15 minutes twice a week. She has a gym downstairs and is hoping to get into better shape and start walking 3 to 5 times a week. When you see her in clinic, she's febrile, her heart rate is 80, her blood pressure is 140 over 92 millimeters of mercury, and she's saturating 100% on room air. Her physical exam is pretty unremarkable, except for a BMI of 31. She doesn't have any ulcers or toe deformities related to her diabetes. You get some laboratory work for her during this visit, and her A1C comes back to 8. Her BMP is notable for a creatinine of 1.7 and a GFR of 50, and you look back to her previous labs from her last hospital, and it's been stable over the last 5 years. Her CBC is normal. There's a urine microalbumin done as well, which is 20, and the normal is less than 30. And then below, you get a lipid panel. So her total cholesterol is 190, her LDL cholesterol is 62, her HDL cholesterol is 33, and her triglycerides are 280. And I'll kind of pause right there, and I'll have Dr. Santos maybe comment on the case. And Dr. Brown, if you could jump in as well, that'd be wonderful.
Oh, hey, good evening, everyone. It's a real privilege to address you from Brazil. I'm really a very good fan of FNLA that actually I'm a lifetime member. I was honored 2 years ago, so really good to be here. So, my friends, I think this is not so easy to deal with Kay, right? Because we're talking about someone who has not only diabetes, but also lots of comorbidities, hypertension, obesity, has a target organ damage, and still persists with uncontrolled risk factors. Of course, we're here to discuss her atherogenic residual dyslipidemia, despite the fact she's taking a good statin and a good dose. But actually, you have to think about the other comorbidities that are happening at the same time. So, especially blood pressure that is still high, the diabetes that's still uncontrolled. And I guess in addition to the lipids, that definitely this complicates and increases the risk of our patient. And then I think it's not also very easy to deal with because she's really trying to cope with a more adequate diet, to exercise a little bit. We know how hard it is to lose weight. She takes lots of medications and things are still not adequate, right? She's vaping. So, it's definitely it's a challenge not only for us as physicians, we have to take care of her and try to reduce the risk of events the more we can, but also for the patient, actually to cope with the more adequate lifestyle, try to lose weight that we know is not easy. She takes lots of pills, and we're going to discuss giving her more medication. So I think this is how to have to see that. And certainly when we're focusing on the lipids, we know that, and I'm going to show later some slides actually, that this patient, despite the fact that her LDL is around 60, she has still high triglycerides, still low HDL cholesterol, and that is associated with the greater risk of recurrence of events. Now, she already had her MI, but she runs the risk of having another one or even dying. So definitely we have to see that, understand that this is a very high risk person. And we must try to do what we can in order to reduce this risk. I think then we're going to discuss it a little bit further, the lipids and all the stuff that we can do for her. But I guess for starters, I think this is not so easy to deal with case.
Yeah, I totally agree. I always say that it's easier to prescribe medication than it is behavior. And despite her best efforts, she's eating out a lot. She's got a fair amount of carbs in her diet. She lays potato chips is flooded with oil and calories. So despite her efforts, there are a lot of things she needs to do behaviorally. And the old saying that the problem with willpower is it has a half-life of 2 weeks and it's soluble in alcohol. And she's drinking a couple beers every other day, which is not helping her triglycerides. And then the renal insufficiency, of course, is another additive thing to her risk. So as Raul, as you said, she's got multiple uncontrolled risk factors, and she will need aggressive control of several of them, including trying to reduce her ApoB levels, which you know are going to be high with that triglyceride level and the low HDL.
Oh, definitely. And one thing, Alan, that, because her LDL is still, we're going to go for the lipids, but her LDL is still high, right? And as I said, ApoB still high because we know that they are atherogenic. We don't have the ApoB determination here, but we know that this patient has a lot of pro-atherogenic lipoproteins in her blood. Not only still LDL inadequate, but also the VLDL remnants, and so her known HDL cholesterol. So whatever measure that we use to identify this higher risk, they're all inadequate, right? And we must find ways of reducing this. I think we can move on.
Yeah, Nidhi, if we go on with the slides.
Yes. Sorry, y'all. I think I got kicked out of here. Okay. I did have an audience question for everybody to start with, to kind of take a step back and think about why patients with diabetes get hypertriglyceridemia. So I think Chris is going to be able to put out an audience poll question. So which of the following best explains why hypertriglyceridemia is common in patients with type 2 diabetes? Increased hepatic production of triglyceride-rich lipoproteins due to insulin resistance, decreased hepatic lipase activity leading to reduced triglyceride breakdown, increased clearance of chylomicrons and VLDL particles, or upregulation of lipoprotein lipase activity. We'll let the audience members vote, and then once we reveal the answers, I'll let Dr. Santos go into the correct answer.
Okay, guys, please vote. We could put a little song in the back, so while we're waiting for the results. Okay. 76% voted in letter A, actually. And so, Nidhi, can you move on with it? And I guess your guy's right? So actually, basically, insulin resistance leads to, actually, we have two things, right? We have overproduction of VLDL particles, and also we have some reduction in lipoprotein lipase activity that reduces the breakdown of triglycerides. So that's why we have this more elevation in these triglyceride-rich lipoproteins. One thing is that actually when we have the accumulation of the remnants, so these remnants are proatherogenic, right? Because they not only carry cholesterol, they can carry cholesterol to the arteries, but also they're pro-inflammatory also. So that's why we know that this kind of dyslipidemia can lead to atherosclerosis. Some people don't believe in HDL anymore. I don't like low HDL levels. I'm old school lipid guy. I did a lot of stuff with Ernie Schaefer. So it's a marker of bad things, even if we know that raising HDL is not going to make so much difference, but it's a marker of bad things, in my opinion.
Yes, and I
Okay.
think it's interesting that, the increased fatty acid production by the liver, which is aggravated by the insulin resistance, makes more VLDL. And then those particles, as Raul eloquently said, turn into remnant particles and VLDL breakdown products. But also, those triglycerides from the VLDL get transferred to LDL and HDL through the action of CETP. So if you remember your metabolism, normally HDL is just cholesterol, so it really can't be digested by lipases. But if you fill it with triglycerides, it will be, and it gets small and goes out in the urine. And by the same token, when triglycerides are high in these patients, they transfer triglycerides from the VLDL to LDL. And then the LDL, which is normally just cholesterol, becomes smaller as the triglycerides are removed from the particle by lipases. So that's how you get small, dense LDL and how you get very numerous numbers of LDL particles. And CETP activity goes up when these patients overproduce VLDL. So when you think about ApoB levels or non-HDL, giving you an idea of the number of particles, they not only have small, dense particles, but way too numerous atherogenic particles due to the effect of triglyceride transfer from triglyceride-rich particles like VLDL into LDL and HDL. And low HDL,
Yeah.
I'm sorry.
And I guess this LDL of 62 that doesn't seem to be so bad misleads us a little bit, right, Alan? Because as you said, if we measure ApoB, we'll see their number of particles is elevated, right? And one thing I think that we had emphasized a few minutes ago is not only because we have the substrate for overproduction of VLDL, but if our patient, right, she doesn't exercise, so that doesn't stimulate lipolysis. She eats a lot of carbs. She still drinks more than she should. So it's more fuel for production of triglyceride particles in the liver. So that's why I think lifestyle here is so important in order to reduce the production of VLDL particles. Okay, let's move on.
Awesome. So back to our case, our next question is for our patient, what is the next best step in pharmacologic management for this patient? Is it to start icosapent ethyl, add ezetimibe to further lower her LDL-C, initiate fenofibrate, or is there no additional lipid therapy needed? And you guys can vote in the poll.
I guess we all agree that their lipids are still inadequate, right? And I think this field of moderate hypertriglyceridemia or combined dyslipidemia is quite challenging to us all because some fish oils may not work, fibrates may not work, and we still know that this patient is still high risk. So what should we do, right? Because some people say, oh, let's maybe put LDL to the range of maybe 20, 30 milligrams per deciliter and see whether we can go further. Or maybe with some kind of triglyceride modifying therapy, we could bring some benefit for the patient. I guess, I don't know, we don't have CRP in this patient, but I guess it should be elevated because all the comorbidities that she has, right? So inflammation also. So, okay, so 58% of our colleagues voted for starting icosapent ethyl, and I guess this is the most adequate answer, right, Nidhi? I think we can move with the right answer. And actually, as I was saying, because we have evidence from the REDUCE-IT trial that actually in a patient like this one, icosapent ethyl would bring benefit. And quite interesting, apparently the benefit had nothing to do with triglyceride lowering. So, or it's very little is explained by triglyceride lowering. And we know that this specific formulation of fish oil is quite interesting because it has properties that might be anti-atherogenic, right? So I think this is, of course, the story is not over yet. We still have some trials that will be being developed in the future in this population. I think commenting on the answers, Alan, so I think it would be not so bad to add ezetimibe also. We don't have, so robust evidence as we have for icosapentae because we have a whole clinical trial on that, but maybe we could further lower the ApoB particles. What do you think?
Yeah, I think you would get some benefit from that. I don't think the magnitude of benefit would be the same as the icosapent ethyl, which had really a surprising amount of benefit. And as you pointed out, probably not mediated so much, or certainly not only by the lipids. Just one comment here. She's on a good dose of statin and her LDL is low. And I think people forget that in the statin trials, almost all the benefit came from patients like this, low HDL, high triglyceride patients. They got the most benefit in statin trials, and they almost drove all the results. And we forget that because I think, as Raul alluded to as he was discussing this, the temptation is to chase the triglycerides first. But these patients really get, because they're the highest risk for cardiovascular events, the insulin-resistant patients, they get the most benefit from statins, even more so than those patients who just have moderately elevated LDL with normal triglycerides. So statins, the first thing, we know that icosapent ethyl has been proven to give cardiovascular outcome benefit. So has ezetimibe. Adding fenofibrate in this patient will lead you down a path. Don't forget that fenofibrate can raise creatinine. And I have seen multiple patients like this who got put on fenofibrate, and immediately their doctor said, "Oh, diabetic nephropathy, getting worse," and sent them, to a nephrologist. And even if their baseline creatinine is not that elevated, you have to be cautious on fenofibrate. So you don't have outcome benefit on top of a statin. You have potential for a misinterpretation of the creatinine elevation as a complication of diabetes rather than the drug. And you don't have those issues adding icosapent ethyl. So that's why I tend to use omega-3s in these patients, and particularly icosapent ethyl.
Yeah, and the thing about the fibrate is really complicated, right? Because we have the trials with fenofibrate, we had prominent with emafibrate, and actually these trials were negative. And we had a quite similar population to this patient here in prominent, and it simply didn't work, right? In spite of the fact that triglycerides went down. We're going to discuss a little bit later the ApoC3 inhibitors, and maybe one of the possibilities why prominent was negative is because we reduced triglycerides, we reduced remnant cholesterol, that is cholesterol carried by VLDL remnants, IDLs, etc. But ApoB particles didn't go down and LDL went up, right? So, we might take some bad guys, but we can keep some, still at the same time, keep some bad guys in the room. And so now, the thing about improving lipolysis doesn't mean necessarily that we're going to reduce the number of pro-atherogenic particles. So, and actually there's one commentary in the chat about why not, emphasizing the need to reduce ApoB particles. And I agree with that. And definitely if we give a fibrate, we wouldn't be doing that. So that's the thing. Is there still room for fibrate in these patients? We have some interesting evidence actually from prominent with peripheral arterial disease, so microangiopathy. We have one study called LENS with fenofibrate in people with diabetic retinopathies, actually indicating benefits for the patients. But we don't have, even with this evidence yet, for microangiopathy in these patients, approved indication for fibrates for microangiopathy in diabetic patients. But maybe in the future we might have. But as Alan said, creatinine might go up with this one, with this drugs.
Yeah, I don't want anybody to think that I would never use fenofibrate. I think it's a a drug to try to avoid pancreatitis. So if this patient had triglycerides 500, 600, 700 or 1,000, then you'd probably use an omega-3 and or fenofibrate, or start with fenofibrate. So I kind of have a personal rule that if triglycerides are over 500, you tackle that first to avoid pancreatitis, see where the dust settles, and then treat to try to reduce risk of cardiovascular events. But when the triglycerides are under 500, you're going to focus primarily on ApoB, whether you do that with statin plus ezetimibe or statin alone, and then the icosapent ethyl effect. We still don't know exactly how that works, but there's clearly benefit.
But you know what, I think coming back a little bit about the ApoB, maybe as you said, reinforcing the statin dose, adding ezetimibe, and okay, icosapent ethyl, we have a strong trial, and I guess the costs, at least generic Rosuva or Itorva and ezetimibe are not so high. And we could do the three things together. Okay, I was talking about compliance with therapy with tons of pills, but we must think about that this patient is a special patient, and we need to take the best care of her that we can, you know. Okay, so next question.
Next question. Which of the following correctly describes the FDA-approved indication for icosapent ethyl? And you have your answer choices below.
I think one important thing that we have to say while you guys are voting is that icosapent ethyl could be used for severe hypertriglyceridemia, except for chylomicronemia, because actually paradoxically it can even increase triglycerides, because omega-3 fatty acids are long-chain fatty acids that get into the chylomicrons and are not broken when we have a genetic disease, but they can help reduce triglycerides. But here the indication that we're discussing about is the reduction in the risk of events, right? So that's why actually most of you voted in the right one, B, right? So this is what is approved, and actually with an indication for prevention of events, not necessarily reducing triglycerides, but actually being used in moderate hypertriglyceridemia with high risk of cardiovascular events, right?
Yeah, that's important. People who got enrolled in the study had to have triglycerides over 150. And there was a group of them without CAD, but with diabetes and risk factors, and they got benefit, as well as those who had established CAD. So I think it's really important to remember what the REDUCE-IT trial showed and which patients were included.
And there was another question from the audience for you all from Dr. Ann Goldberg. Would you consider a GLP-1 agonist in our patient?
And nice to hear from you. Definitely, this is something I'd consider for this patient. Actually, I have a slide on that because, you know, and one thing that I think that for us has always been a challenge is because we always treat the consequences of visceral obesity, right? We never had actually adequate tools to treat the cause of that. Take away the visceral fat, take away the liver fat. And I think, in my opinion, GLP-1 agonists can make a lot of difference for our patients because they reduce the risk of events in people with obesity, without diabetes, and already have cardiovascular disease. And they reduce the risk of events, atherosclerotic cardiovascular events, in a patient like this one, right? So coronary heart disease, person with type 2 diabetes. Actually, we have also benefits for people with CKD and type 2 diabetes. So definitely this is something that we must consider. And I was talking about the possibility of having CRP values in this patient. Let's believe that this is high because this is a pro-inflammatory condition. And we know that GLP-1 agonists, they have anti-inflammatory properties. And this is something also that maybe we should consider about not only reducing weight, improving the control of type 2 diabetes that's not adequate in this patient, and certainly reducing the risk of kidney events and cardiovascular events. So this is something. And as you see, people, that we have different approaches now for a patient like this. Of course, it gets complicated if you start giving 3 or 4 different drugs on top of someone who's already taking a lot of pills. But we must, I think, and try to identify which would be the most adequate therapy for this patient. I don't know, Alan, what do you think about?
I love the idea of a GLP-1. It solves a lot of problems. I bet you her diet will change. She definitely is going to lose some weight. She probably will cut back on her drinking too. I would have little doubt of that. So you have some improvement in her A1C and cardiovascular outcome benefits. So actually, all of those things that we kind of started the conversation. She's got complicated situation with multiple problems, and I think that would be important. And I can't tell you how many times I communicate with people's endocrinologists about asking them to either add a GLP-1 or an SGLT2 to a patient with coronary disease and diabetes. So I love that idea.
Me too.
Our next question is focusing on fibrates. So when should fibrates be considered in a patient with type 2 diabetes and hypertriglyceridemia? If their triglycerides are greater than 500 to reduce pancreatitis risk, if their triglycerides are between 200 to 499 to reduce their cardiovascular risk, LDL-C of greater than 190 and triglycerides greater than 200, or fibrates should not be used with statins due to myopathy risk. And then there's another question in the chat after this one, Dr. Santos and Dr. Brown. Is there any benefit of gemfibrozil over fenofibrate in patients with hypertriglyceridemia?
Let's see the results and then we can comment on that.
Yeah.
Gemfibrozil.
Wow, that's a majority. 92% voted for 8.
We kind of explained it earlier, so we agree with. I think everybody agrees with you.
No issues at all. So definitely. And what about the comparison of gemfibrozil with fenofibrate? Actually, the 2 trials that were positive with the fibrates were done with gemfibrozil, right? But the issue is that we can't associate gemfibrozil with statins. And we know that the statins are the cornerstone of our therapies because the benefits of statins are much greater than the one that were achieved with gemfibrozil in the VA trial and also in the old study with that drug. So that's the issue. Helsinki Heart Study, yeah. So that's the big issue, associating them, because that indeed increases the risk of myopathy and complications, and especially in a patient who has CKD, you must be careful in associating these two drugs, right?
Agree completely. I mean, the VA HIT study led us down a path because it was the only study where we added a lipid agent, gemfibrozil, and we didn't change LDL at all. We just lowered triglycerides and raised HDL. And it did show benefit compared to placebo. Those patients were not, statin patients. So there was excitement that here we had a study that showed just manipulating HDL and triglycerides without LDL manipulation gave benefit. And then everybody thought, well, if we add a fibrate on top of a statin, we're going to get additive benefit. And it just didn't work out that way when we added fenofibrate to a statin. And fenofibrate was the choice because it was very rare to get rhabdomyolysis adding fenofibrate to a statin. And it started to become an issue with gemfibrozil. So as Raul already said, we don't use gemfibrozil with a statin, and it would be wrong to not put this patient on a statin. And in fact, statins will lower triglycerides up to 30%, even in patients with severe hypertriglyceridemia, with the exception of FCS. So in those patients with really high triglycerides who have a risk for CAD, a statin plus fibrate and or omega-3s makes sense.
There's another question comparing icosapent ethyl and fenofibrate. So somebody asked, how do you know which to add first, icosapent ethyl or fenofibrate when triglycerides are greater than 500?
That's an easy one. If they have CAD or diabetes, you would add icosapent ethyl because you have cardiovascular outcome benefit.
Yeah, yeah,
And then you do not have it when you add fenofibrate to a statin. We could argue about how those studies were designed, but in reality, we don't have any data that you get CV benefit. So what generally happens is if you've got a 25-year-old with familial hypertriglyceridemia and maybe an episode of pancreatitis and not diabetes, you might go with fenofibrate. You're not really worried about cardiovascular risk. You're just trying to reduce pancreatitis. And it's easier to take one pill a day than, 4 capsules of omega-3. If you have a diabetic or a patient with coronary disease, you're going to go with icosapent ethyl because of the outcome benefit. Raul, do you agree with that?
No, I agree. I fully agree with you. Yeah, definitely.
Awesome. Our next question is, which of the following macronutrient adjustments is recommended to specifically target hypertriglyceridemia in patients with type 2 diabetes? Is it to increase your total protein intake? You have all of these influencers talking about increasing your protein to greater than 30% of your daily caloric intake. To replace refined carbohydrates with fiber-rich complex carbohydrates, eliminate dietary fat to prevent triglyceride absorption, or increase intake of trans fats to promote lipid oxidation. We'll give you guys a second to answer that.
This is real nutritional science, right? Yeah. And take away the alcohol also.
Right, exactly.
Yeah. Okay, so 85% voted for B. So yeah, definitely we must take away the refined carbohydrates, increase the fibers. We should take the alcohol away also. So because this, as I said, they are fuel for overproduction of triglycerides by the liver and consequently having hypertriglyceridemia. And also our patient needs to lose weight, right? So definitely calorie restriction is extremely important because otherwise it's going to get hard. So we can come back a little bit to the issue of GLP-1 agonists because we know that our bodies, they're totally, when you get fat, it's very hard to lose weight because the metabolism changes in such a manner that you start, let's say, burning the calories, even if we increase our exercise, etc. It's very difficult. So definitely having these drugs, the GLP-1 agonists, the dual agonists that you have in the US already. We don't have it already in Brazil, but they have only the GLP-1 ones. Definitely, I think these drugs have an important role for really changing these patients. And actually, when they lose weight, triglycerides go down, right? So we have evidence that these drugs have moderate effects, but favorable effects in reducing triglycerides. Also, they reduce CRP. I mean, discussing a lot now about inflammation and residual risk, right? So Paul Ridker showed that actually in patients like this one with moderate hypertriglyceridemia, taking statins, CRP is a good marker of recurrence of events. So GLP-1 agonists, in my opinion, they bring benefits in part because they're anti-inflammatory drugs also. No.
Just a quick comment on diet here. This is important in diabetics, which is what the question is, type 2 diabetes, to replace refined carbohydrates, give them more complex fiber-rich carbohydrates. The only thing I would just throw out there as an interesting point is patients who have chylomicronemia. So in patients with familial chylomicronemia syndrome, you would not want to increase fat intake and decrease carbs in the same way. So I'm bringing that up because if you have a patient, and we talked a lot recently about familial chylomicronemia because we have a therapy, but if you have a patient with FCS and they're having recurrent pancreatitis and they develop diabetes secondary to the pancreatitis, which wouldn't really be type 2 diabetes, but they can have post-pancreatitis insulin deficiency and develop diabetes. And you didn't realize, you weren't a lipidologist. You might send that patient for a diabetic education. And if they're given the traditional diabetic diet, they'll actually get worse because they're going to get a higher fat, low carb diet. So it is always important, especially in patients with pancreatitis, which came first? Was it uncontrolled type 2 diabetes that led to the pancreatitis, which means they're less likely to be FCS? Or was it recurrent pancreatitis that led to the diabetes in an FCS patient? And that's why it's so important to have a dietitian in your institution that understands lipid disorders, as well as a lipidologist who understands lipid disorders. So I'm just throwing that out because you have to know why that patient has high triglycerides to give the right diet, particularly in the severe hypertriglyceridemic, not in the.
Yeah, I agree.
And someone asked in the chat, is there any benefit to change in diet, like plant-based or Mediterranean diet? And I think that's also what the question is hinting at, because in both of those diets, we know that patients get more fiber-rich carbohydrates as well.
Yeah, I think it's interesting. Yeah,
it's the least inflammatory diet, also.
Right. The next question is about novel therapies. So which novel therapy targets ApoC3 and is being investigated for its role in severe and moderate hypertriglyceridemia? Is it inclisiran, evanicumab, olezarsen, and plozasiran? Sorry.
Those are weird names.
Long names.
Olezarsen and plozasiran.
Plozasiran or bempedoic acid.
The newer drugs always have funny names, right? And hard to pronounce them. And I guess Alan has one nice slide on ApoC3 because I think we need to learn a little bit about it. So most of our colleagues voted for C, and definitely these are the two drugs that are being developed. Some already approved for FCS, some are on the way. So Alan, please talk a little bit about ApoC3 because actually we're not really okay. The lipidologist knows a little bit about this, but the usual clinician that sees patients not much aware, right?
Yeah, so it's very interesting that it is to us lipid geeks that ApoC2 rides on all particles with triglycerides, whether it's VLDL or chylomicrons, and ApoC2 activates lipoprotein lipase. ApoC3 seems to be quite highly prevalent on particles in patients with insulin resistance, and it inhibits lipoprotein lipase, which would inhibit the breakdown of triglycerides from chylomicrons and VLDL, as well as their remnants. So I think by mistake, olezarsen and plozasiran studies started with looking at patients with familial chylomicronemia syndrome who have non-functioning lipoprotein lipase, and maybe they were thinking if we remove inhibition on the lipoprotein lipase by removing ApoC3, we might get a drop in triglycerides. But those patients had broken lipoprotein lipase, so removing inhibition on a broken lipase shouldn't do anything. But it did. It worked. And so we found out that the absence of ApoC3, it expresses receptors on the liver to pick up triglyceride-rich particles and remnant particles. So when you think about that, that might reduce atherosclerosis. The other thing is that in knockout populations, people that have knockout mutations where they don't make ApoC3 have very low incidence of atherosclerosis. And then the third thing is there's a lot of theoretical reasons why increased ApoC3 should be pro-atherogenic, which I've shown on this slide. But I think what's fascinating is if you overeat or the ApoC3 or you get obesity, your liver increases production of ApoC3. So it actually aggravates peripheral insulin resistance. The ApoC3 can affect the muscles' resistance to insulin, And ApoC3 can also be produced in the pancreatic islet cells, and that leads to increased insulin resistance by the beta cells and increased apoptosis of pancreatic beta cells. So ApoC3 is a bit of a culprit in aggravating insulin resistance and probably stimulated by increased caloric intake and obesity. And then if you look at statins, PCSK9 inhibitors, niacin, ezetimibe, they increase the removal of ApoC3 from the circulation. So we know they're going to reduce remnant particles, et cetera, which should reduce the risk of atherosclerosis. But when you do increase plasma levels of ApoC3, you reduce triglyceride-rich lipoprotein lipolysis, you have increased remnants, hypertriglyceridemia, and also increased accumulation of those lipoproteins in the arterial wall. So it's pro-inflammatory, it aggravates insulin resistance, leads to increased atherogenic remnant particles. So even though the current new drugs that we discussed, olezarsen and plozasiran, have been tested in people with familial chylomicronemia syndrome to try and reduce pancreatitis, there is potential that treatment that reduces ApoC3 may actually reduce atherosclerosis. So there are some studies underway now looking at patients with more moderate hypertriglyceridemia and giving them drugs to lower ApoC3 to see if it's safe, and then probably the next step would be a cardiovascular outcomes trial. So
yeah, actually, this is a slide that I brought from a recent paper that was published. We testing one of these drugs, in plozasiran, that blocks the production rate of C3 in people with mixed dyslipidemia. Kind of patient that we have on our case here. And you see that actually these drugs are very robust in reducing ApoC3. You see 50 to 90% reduction in ApoC3 concentrations. For instance, fibrates reduce ApoC3 by 25% only, right? And you see here that in addition to reducing triglycerides very robustly, these drugs reduce ApoB. And differently from fibrates, because fibrates, they tend to increase the lipolysis from VLDL, IDL to LDL. So we might have a paradoxical increment in LDL particles. We see here that actually LDL goes down, especially ApoB goes down. And that's why we believe that actually these drugs might have an interesting possibility of reducing the risk of atherosclerotic cardiovascular events in patients with mixed dyslipidemia. So because they take away the VLDL remnants, the IDLs, they do not increase LDL, they reduce the number of proatherogenic particles. So I think that's why we need a clinical trial. Actually, there's one trial with olezarsen that they're using a surrogate. They're doing CT angiography, and they're trying to show if olezarsen will change the unfavorable plaque characteristics that are associated with the greater risk of events. And then we'll have this trial called CAPTAIN with plozasiran. Actually, the idea is enrolling patients with moderate to severe hypertriglyceridemia. Actually, we're not going to end with, let's say, triglycerides until 500. Actually, the idea is really testing patients with triglycerides between 150 and 200 to almost 900 milligrams per deciliter. Because actually, if you take a look at this week's European Heart Journal, we published a paper actually where we tested the association of triglyceride levels in the clinical trials that tested all these drugs, reduce it, strength, and prominent. And also we took patients from the Women's Health Study and also from the Copenhagen City Heart Studies, and actually we saw that actually people who had actually higher triglyceride levels between 500 and almost 900 actually had a greater risk of events than those who had triglycerides between 150 or 200 and 500. So the idea for CAPTAIN is that actually we include these patients with higher triglyceride levels. Of course, one may say, oh, but are you going to get worried about these patients with higher triglycerides having pancreatitis? Definitely we must not include patients who drink a lot and patients who have uncontrolled type 2 diabetes, because that increases the risk of pancreatitis. And actually, I think one of the questions in the chat was about the use of fibrates for people with triglycerides over than 1,000 instead of over than 500 for reduction of pancreatitis. Actually, the absolute rates of pancreatitis between 500 and 1,000 milligrams are not so high. And actually, they really start to get higher when they're over than 1,000. So in this study, I think that's been planned, Captain, I think it's going to test this drug. And hopefully this study will really show that actually taking away the triglyceride remnants will reduce the risk of events.
Yeah, I just want to comment on two things. Number one, the reason generally 500 is where you would think about treating triglycerides is because 2 beers can get you over 1,000. So, it doesn't take much indiscretion if you're over 500 to get you over 1,000. So that's, I think, why, if you look at the indications actually for patients to get fenofibrate or icosapent ethyl for high triglycerides, 500 is kind of the magic number, but we're trying to keep them below 1,000 for the reasons that Raul so eloquently said. I see Carol Kirkpatrick is on. Carol, it's good to hear from you. And she just wanted to point out something that's important, which is that in a patient who did not want to, like our patient who didn't want to take a GLP-1, you could consider a diet of moderate protein, in other words, 20 to 25% total energy, moderate carbs, high quality fiber, and moderate dietary fat, and emphasize daily exercise. So that patient who might be averse to taking additional drug therapy with a good dietitian would get excellent advice. Thank you for that, Carol.
And Dr. Brown, Dr. Santos, someone else in the chat asked, why does glycemic control worsen with plozasiran?
This is a quite very intriguing question, actually, because if you take a look at people who have loss of function mutation or variance in ApoC3, there's no increment on the risk of type 2 diabetes, no increase in glycemia. And paradoxically, we found the increment in glucose, especially in people who had type 2 diabetes, but actually their HbA1cs were already higher at baseline. We don't know whether there's an increment in the production of glucose by the liver when we give ApoC3 inhibitors. And this is something that we still need more data to really understand why is that. I don't know, Alan, if you have any inside information, but
I don't. I think it's interesting because ApoC3 actually tends to make people insulin resistant, and with the knockout mutations, and not with drug therapy, my recollection is they had a lower incidence of diabetes. So I'd have to double check that to make sure that's true.
Yeah, the thing is that the number of patients in these trials were still small, so that's why we need bigger trials and to see whether this is true. But it applied only for those who already had diabetes and where their glucoses were a little higher, so not the whole population. Actually, there's some concern about also the ANGPTL3 inhibitors that actually might have similar effects than the ApoC3 inhibitors, and this is something that also is being sought also in these people that are taking these newer anti-ANGPTL3 drugs. Yeah.
I was going to go through the challenges of this case and then just open it up to the audience for further questions for you. And then Dr. Santos, if you want to share any specific slides, we can do that as well.
Yeah, basically, this is really what I said in the beginning of our discussion here. So this is a complex patient, right? She has many diseases. She has complications of these diseases. And she has uncontrolled risk factors, concomitant risk factors, and it's a challenge for all of us. It's a challenge for the patient, challenge for all of us. But the good news is that we have many alternatives nowadays that we can think about. Right? Not only a more adequate lifestyle that we know sometimes is hard to follow. Definitely, we must have a multidisciplinary team to help us in achieving the changes that are necessary. And we have many medications that can make a lot of difference for the patient. And we must think identifying the one that would go better. And I think one thing that is extremely important is not have inertia in changing the therapies. And if we see that these therapies are not working out, if they're not doing what they were supposed, we must think about using the alternatives, because the good news is that we have alternatives now. So we can think about different therapies that could help improving the risk of our patient here.
Thank you so
I
much,
put some
Dr. Santos.
I put some slides, but it's very quickly. So this is just showing what we have. So negative trials, see similar patient, negative trial with the PEMA fibrates. So that's why we should not use fibrates for these patients, at least for prevention of macroangiopathy, right? Then the next one, Nidhi, I think is the one reduce it, right? So that's we were discussing about the use of icosapentio for this one here. Favorable results of reduce it trial in a similar patient. Then the next one, and then that's why I think Ann Goldberg. So remember us and asked us about the possibility of using a GLP-1 agonist for this kind of patient, because we have very robust evidence for this group of medication in a patient like this. So definitely many options here. And I think I have one more. Just move on, please. No, for the next one. No, I think it's not here. Okay, I was just going to show that we reduce CRP and triglycerides in these patients. So, but basically, I already talked about that.
Well, I want to thank everyone. I mean, this was an outstanding presentation from Dr. Patel, Dr. Santos, Dr. Brown. Well, it's an all-star team of lipid specialists. This is recorded. It'll be at lipid.org, as you can see on the screen. But I want to remind you, the Lipid Panel is a monthly panel, and it's always the last Tuesday of the month. And next month we have What is Plaque? How do we measure it and why? Dr. Seth Martin will be moderating. Dr. Ron Blankenstein and Dr. Peter Libby will be joining us. So I hope everyone can return next month. And again, a big thank you to Dr. Brown, Dr. Santos, and Dr. Patel. And Raul, this is our first international lipid panel, one of many to come.
Great honor. Thanks very much, guys, for inviting me. So Nidhi, Alan, so it's a real privilege to be with you guys. I hope I can see you in the future. I'll be in Chicago for the ACC. Maybe we can meet there.
Great.
Yeah,
Fantastic.
yeah.
Great.
Yeah.
Terrific. Everyone have a great night, and thank you for joining us.
Bye-bye.
Bye. Thank you, everyone.